This patient presented to me with tooth number 19 in place and tooth number 30 in place. Before extractions were performed, tooth number 19 fell out. This gives us the ability to do a controlled study of the patient where one site was able to be rebuilt and one site unable to be rebuilt. Where tooth number 19 was rebuilt, where tooth number 30 was rebuilt, you can see right now an 8-year postoperative radiograph where the site was filled with anorganic bovine bone mineral mixed with calcium sulfate. In a later part of the series, we'll see the histologic result of this healing. However, what we can see clinically is full ridge preservation, both on X-ray, and we can see keratinized gingiva and alveolar volume performed on the slide below. However, if we look carefully at the X-ray, even at 8.5 years postoperatively, we still see the graft material in place on X-ray. We know that if a graft material is still in place radiographically at this time period, that clinically the graft material will still be there if we look histologically. The problem with the graft material remaining histologically in alveolar bone is this can change the quality of the bone. Bone itself is an elastic, remodeling, vital structure. If there is an inorganic portion of it, the bone no longer has the same elasticity and the bone no longer has the same ability to resorb and remodel according to the body's stresses. Ideally, when a bone graft material and or barrier are placed to help a site rebuild with bone, we would like any graft material to resorb, leaving 100% vital bone in the site, which can remodel according to the body's stresses, whether or not a dental implant is placed. On the other side of the screen now, you can see where tooth number 19 fell out. We have both vertical and horizontal collapse of the site. We also see complete loss of keratinized tissue in the area. To rebuild this site with bone, vital bone, before placement of a dental implant will require a significant reconstructive surgery for the patient. If we look more closely at the clinical slides, postoperatively on both sides, again we can see in the patient's right side, number 30, full reconstruction of the keratinized gingiva and alveolar ridge. On the left side, we see buccolingual collapse and vertical collapse as the literature shows us. If we look at the vertical view from the occlusal portion of the patient, again in the green we can see where the site was grafted. Even though the graft remains radiographically, we can see clinically it performed the procedure that we wanted and preserved the full volume of the alveolar ridge. And again on the left side we see almost no keratinized tissue and complete loss of buccolingual width in the site. If we do not treat a socket at the time of extraction, as we saw in the previous patient, we have disuse atrophy. The bone disappears, we get lingual displacement of the alveolar socket, and in this case, a much greater proximity to the alveolar nerve, precluding placement of a dental implant in the area. Patients like this often do not have the available bone to even support a removable prosthesis, nor a fixed prosthesis with an aesthetic pontic. This patient had tooth extractions, the sites collapsed, and you can see where pontics are present under the fixed bridges. You can see very large and unaesthetic pontics that do not look like natural teeth emerging from the dental gingiva, as we would like either with our fixed prostheses pontics or our dental implant supported restorations. This patient as well presented after extraction and healing of the site. You can see rather than a 12 millimeter alveolar ridge width, which we would normally see around a lower molar, the ridge width is only about 2 to 3 millimeters with only 1 millimeter of keratinized gingiva. Again, an unaesthetic, physically unacceptable site for placement of dental implants. If we treat an alveolar socket with a graft and or barrier material, in addition, this justifies part of the cost of the procedure to the patient. This is yet another procedure we are performing in rebuilding the patient's entire mouth as part of their entire health process. We can see something on X-ray, but unfortunately, as we saw from one of the other patients, if you see a graft material on X-ray, often that means it has not resorbed and will remain clinically and radiographically over time. No treatment, again, leads to soft tissue collapse and the possibility of an unesthetic result, either with a fixed bridge pontic or a dental implant supported restoration. If we look at some of the costs of treating versus non-treating an extraction socket, we can see that our graft material and barrier combination can cost anywhere from $100 to $1,000. We can use simpler grafting and barrier techniques that you will see over the course of the next few lectures, how these can be used to successfully augment a dental socket with full fill of alveolar bone. We can compare these treatments to the performing of a sinus augmentation, lateral or vertical ridge augmentation, which can cost $2, $3, $4, or more $1,000, add 9 months to a year and a half to treatment time, and often may preclude the ability for the patient to either afford or be able to handle emotionally or in a timely manner reconstruction of the site prior to placement of dental implants. These patients may therefore not get fixed implant-supported prostheses. Let's take this patient, for example. As we can see in the 3 sites where teeth were remaining, alveolar bone and keratinized tissue were supported. If we look in the edentulous area where the mandibular central incisors and lateral incisors were, we see a very thin alveolar ridge where there is not the ability to place dental implants. After exposure of the alveolar bone, we can see that for the crestal 5 or 6 millimeters, we only have a 1 millimeter thick alveolar ridge. This procedure that we will show now will be described in detail in future lectures, but what we did was use demineralized freeze-dried bone struts in the area to help support the bone graft that was placed. In this case, the bone graft that was placed was a mixture of mineralized and demineralized freeze-dried bone with an alginate binder called Regeniform. As you can see, the Regeniform material is placed in an ideal shape to reform the alveolar ridge the way we want it. You can see coronally 1 millimeter of lingual native bone and 8 to 9 millimeters of graft material placed on the facial. Material is covered with a long-term resorbable barrier, and primary coverage is obtained in the site. This primary coverage is maintained through the entire 9-month healing period. We need to wait this long because we need to allow a blood supply to regenerate into the graft material, bring with it osteoblasts that will deposit bone on the scaffold that we've laid down. Now we can look post-operatively, and we see a 9 millimeter alveolar ridge width restored where there was only 1 millimeter initially. This enables, instead of what you see on the left, a deficient ridge, we now have plenty of alveolar bone in which to place our dental implants. And we can see pre- and post-operatively how much we've been able to successfully augment this alveolar ridge. What this enables is placement of dental implants to be restored in an aesthetic manner rather than what we used to do, and that was remove the coronal 1 millimeter width of alveolar bone, which in this patient would have placed the implants 3 to 4 millimeters apically, condemning the patients to long and unaesthetic teeth. Histologically, we see the pinker portions of this graft material are the mineralized alveolar bone chips that are placed in the graft, which decreases shrinkage, but the redder sections of this histology show us new vital bone growing all around these pieces. Again, in this section, we have about 50% residual non-converted bone chips, which will convert over time because we have seen osteoclasts on this material, and we see approximately 30 to 40% new vital bone forming in this site. And aesthetically, we can see the final dental implant-supported restoration showing us the normal location and size of the teeth that were placed in the area, as opposed to the patient on the other side of the screen who has not had his alveolus restored, leaving him severely deficient maxilla and mandible. As we have seen from literature going back as much as 35 years, Piotrkowski has shown us that ridge collapse has been seen in dry skulls with a lingual disposition of the alveolus, height and volume collapse in the lingual and apical directions. The greater number of teeth that were extracted in his study showed even more significant alveolar socket collapse. Look at any patient that presents to your practice. Where there is an extracted tooth, if the site has not been preserved, you will see deficient alveolar bone and gingiva for the placement of either a fixed bridge pontic or a dental implant. These sites must be reconstructed for the placement of a fixed prosthesis if we want an ideal aesthetic result. In the early days, dental implants were placed at any angle to integrate them into the alveolar bone. These implants were placed over 20 years ago by a surgeon who did anything he or she could to get the implants placed and integrated. Unfortunately, this leaves the patients with dental implants that have their screw access holes at about a 30-degree axis to the prosthesis. This has over time caused weakening of the prosthesis, unfavorable force distribution to the dental alveolar complex, and loss of bone around these dental implants. Some newer literature out of the Kentucky group, Iasella and Greenwell, have shown that socket preservation will prevent, either by grafting or barrier placement, the loss of width and height of alveolar bone that we see after conventional extractions. What they showed in this one study was if a tooth was extracted and no site preservation was performed, the original site width of 9.1 millimeters decreased to 6.4 millimeters. Well, if we're looking to place a 5 millimeter implant in a posterior site, this only leaves 1 millimeter alveolar bone facially and lingual to this dental implant. That means that the placement of a dental implant will basically remove all of the cancellous spaces and all the blood supply to the buccal and lingual plates, leading the patient to resorption of the buccal and lingual alveolar bone over time. In this same study, where ridge preservation was performed and bone grafting was placed at the time of extraction, there was less than 1 millimeter of site collapse. In this site where a mineralized bone product was placed in the grafted socket, there was 54% vital bone 54% total bone content. However, over half of that was non-resorbed, mineralized freeze-dried bone graft, where the barrier was placed over the extraction socket and vital bone allowed to fill in and form bone after the resolution of the blood clot. There was 100% vital bone in the site, forming about 50 to 60% of the volume. Zvi Artzi and Chaim Tal and his group have done a lot of research with the anorganic bovine bone minerals. What they showed in their socket studies was that with this particular bone, BioOs, they saw only 15% vital bone in the site. However, what they showed is 26 to 35% residual bone graft at 9-month period when the sites were re-entered for dental implants. And again, residual non-resorbed bone graft material changes the vital component of the bone and changes the elasticity whether or not a dental implant is placed. Vance and Greenwell, in another study out of the Kentucky group, where they used demineralized freeze-dried bone combined with Calmatrix, a calcium sulfate product with a bone graft enhancer in it, showed 97% vital bone formation in the socket. 61% by volume of the grafted site became bone with 30% marrow spaces, but almost 100% of this was vital bone with very little residual demineralized freeze-dried bone remaining. However, what they also found was only 0.5 millimeters of site collapse in the area, literally 100% preservation of the volume using this particular combination of graft and barrier materials. So the bottom line is we wish to prevent at all costs extraction site collapse in our patients, one tooth at a time, to prevent them from needing the insertion of extraction site materials at a later date and dental implant prostheses, which are tissue-borne rather than tooth-borne. So what are our concerns when we perform extractions? we need to know what systemic factors may affect our decisions. Systemic factors being diabetes, bleeding issues, other medical factors that the patient has that can complicate healing, smoking and other factors that the patient may have used, other chemical dependencies or physical dependencies may affect healing in the site. Local factors, thin periodontal tissues, thin scalloped tissues may heal differently than a thick, flatter periodontium, needing different reconstructive processes. The predictability of our current techniques, as you will see over the next series of lectures, depends on the graft and barrier materials that you as the surgeon chooses to place at the time of extraction. Some of the materials that you've seen today in the initial lecture in our series, demineralized freeze-dried bone with calcium sulfate, tricalcium phosphate, some of them are fully resorbable and replaced by bone in the 4 to 6 month period in which we would like to place our dental implants. Removable barriers such as the PTFE, the dense PTFE materials, can allow blood clot to fill the site over time and give the patient full restoration of the alveolar defect, whereas resorbable barriers may lead to 2 to 3 or 4 millimeters of keratinized tissue forming underneath the site, and as well may interfere with coronal healing of our graft materials. Immediate socket implants, we know they clinically work. We are not sure yet which graft and barrier materials to place, nor do we yet know what are the best procedures to use at the time of placement to preserve the alveolar volume. Some of the questions with immediate sockets that will be answered in further literature analyses are: what is the bone to implant contact? Does that depend on the surface, the graft material, and how much bone the implant is in contact with at the time of placement? What graft and barrier to use? One technique will be shown now, but other techniques may be developed over time to form more vital bone. If we look at some of the literature on alveolar defects at the time of extraction, what we see at these defects are often reduced with currently used materials and techniques, but they are not eliminated. Reduction of the defect means that secondary graft procedures may be needed to try and gain not only fill the alveolar defect, but bone to implant contact. Neither of these have predictably been shown in humans to result in bone to implant contact of the grafted materials onto the dental implant for functional osseointegration, support of a prosthesis, and support of the soft tissue. This paper by Schropp looked at extraction of teeth, placement of a dental implant 4 to 10 days later, which enabled them to have full soft tissue coverage and resolution of any dental infection that was there in the site. What they did differently was they used 100% autogenous bone to graft the defects, which is still considered by many to be the gold standard for grafting material, and then they performed a re-entry 6 months later at the time of implant uncovering. If you look at these two slides taken from the paper itself, you can see that when there was a dehiscence present at the time of extraction, which you see as the larger defect, at the time of re-entry, these dehiscence defects were not fully resolved. So that even using the gold standard of alveolar bone regeneration, autogenous bone, these defects were not eliminated. And if we look carefully at the author's own conclusions from their paper in 2003, we see that only 50% of the alveolar defects were restored either in height or width, which means that these patients, if analyzed carefully, still have a tremendous alveolar defect that needs to be filled with bone. This bone needs to then osseointegrate to the dental implant to support a dental implant supported prosthesis and to support the keratinized gingiva that we wish for our aesthetic dental implant restorations. Berglund, Linde, and Botticelli, again, in their study of immediate socket implants with their current technologies, found that defects were reduced and not completely eliminated. Other authors have shown, both in humans and animals, that the larger space between the dental implant and the alveolar bony wall these defects are not filled with the same amount of bone, nor the same amount of bone to implant contact, leading to questionable support of the soft tissue in these thin areas. Again, looking carefully at their results, larger defects were filled by collapse of the buccal plate onto the surface of the dental implant. All of these literature evaluations show us that in these patients, the alveolar bone volume with current technologies was not preserved by placement of a dental implant at the time of extraction. So again, what we must consider at the time of extraction is what do we use to protect the socket? What do we want to fill the space? Do we want it only to look good on X-ray, and do we want it only to prevent site collapse? Or instead, in this age of periodontal and alveolar regeneration, do we want full reconstruction of the alveolar bone and gingival housing with alveolar bone supporting keratinized soft tissue? The graft materials that we use, we want to turn over into 100% vital osseointegratable bone. We want these to support the soft tissue, not just because some lecturer told you to do so, whether it's at the podium live or on Dental XP, but we want you to do this because it's the right thing to do for the patient and the site. We don't want this just to make the companies that sell the products happy, but by the end of this series of lectures, you will see that this is the right thing to do for each patient and for each site. In the long run, we want to perform extraction socket augmentation. We want to take the teeth out easily and quickly. We want to leave ourselves time and our patients time to heal atraumatically, and so that we can enjoy the hobbies that we prefer.